Hi, everybody, and welcome back to another episode of ASAP Pathway podcast. I am your host today, Dr. Stacy Ochoa, and I'm here again with my friend and colleague, Dr. Mike DeLuke. If you have been following us, we have two prior recorded podcasts where we had some amazing conversations and we got some really good feedback. I mean, I had a lot of people reaching out to me saying that was an amazing conversation. So if you haven't heard it, please go back and listen. I think it's an important conversation. Share it with not only medical or dental colleagues, but parents. I think it's necessary for them to hear this as well and start being advocates for their own care. But Mike and I decided that we were going to have more conversations just as things develop and just touch base with each other. And it's been so exciting for me because he'll find something out, we'll touch base. I'll find something out, we'll touch base. And it's just really good to keep the new baseline. Like, where are we now and how are we moving forward and collaborating and connecting with colleagues and helping more people. And that's what this is all about. So without further ado, hi, Mike. Thank you.
Hey,
Thanks
Stacy,
for
thank
coming
you.
back.
Yeah, thanks for having me back. I completely agree. It's so much fun to talk and just keep revisiting these issues. I think that's so necessary today.
I agree. I think things are changing. Sometimes not as fast as we want it to be, but I really wanted to talk about a bit about speaking recently in St. Louis.
Tell me about the winds of change. I want to hear about this.
Okay. So, I mean, I'm just very proud of my colleagues that put this together. So the Winds of Change was put together by doctors Maz Moshiri, who's an orthodontist, and Reza Movahed, who is an oral surgeon that has an emphasis on airway health.
Okay.
And you know, the Midwest, people call us like the flyover state. So, you know, we're kind of the last for everything to start happening. It seems like the coasts start things and then we're kind of the last. And so Maz and Reza had reached out to me and said, look, we're putting something together in St. Louis. We're going to talk about the importance of basically, you know, they had heard my message before of dentist triaging basically and identifying maybe at-risk patients that might need orthodontic interventions, airway health. Maybe they are CPAP intolerant, they're adults, and they might need MMA surgery to open their airway. So send them to the oral surgeon. So I was ecstatic. So I'm just so proud that that's happening. And the title, Winds of Change, says everything. And that's what we're all doing. This is what we're all on the cusp of the amazing things that are coming and talking about what's happening in our practices and how we can better, more comprehensively help our patients. And really utilize our skills. And I said this in my lecture was, you know, we are so educated as dental professionals beyond, you know, the white things, beyond the teeth. And I don't even know if people really realize the amount of education that goes into what we
probably most don't. Yeah.
Most don't understand that. And I mentioned that basically, you know, I get this phrase from Dr. Steve Carstensen, who's heavily involved with the ADA's movement in pediatric airway and moving that forward, but calling, instead of general dentist, you know, we're really more of the primary care dentist, and then deciding with our patients, you know, who do we need to refer to? How do we intervene and who do we bring into the team? So just like a primary care physician does the same thing, we are doing the same thing with oral medicine. And when golly, we had some big hitters at this conference. I mean, we had Maz Moshiri, Reza Movahed that put this together. We had Audrey Yoon, and we had Dave McCarty. He's a sleep physician.
Yes, I'm familiar.
Yes, and he is just really it's interesting because he
has
pulled
the
me
podcast.
aside.
You shared his podcast with me a while back.
Yes,
Actually,
his podcast,
yeah,
Empowered
brilliant
Sleep
guy,
Apnea.
brilliant
Yeah,
guy.
Empowered Sleep Apnea. Yeah, he's very creative.
Yeah.
I always jokingly say, to me, it's like, I'm kind of dating myself here, but I don't know if you watched Reading Rainbow when you were a kid with LeVar Burton. It reminds me of Reading Rainbow.
Like, I could see that.
He takes you on a journey, but it's all about airway sleep health, and he's extremely progressive and integrative, and really is partnering and collaborating with dentists and orthodontists. And the things, and he's really wanting medicine and dentistry to be on the same page. So I just really appreciate Dave McCarty, but he had said to me, Stacy, things are changing. You watch, it's coming, it's happening. You know, next year's going to be different, and you just watch. We're on the cusp of the pendulum swinging, and it's coming. And so the fact that we had this discussion in St. Louis, Missouri, and I had the opportunity to listen to, and watch Audrey Yoon present all the things coming down with, Stanford and the research. And oh my goodness, she brought up that they just received, I believe, a research grant for an ultrasound device that actually can detect where collapse is in the airway.
Wow.
Yes, it's ultrasound. So no radiation, no need for DICE. So DICE is drug-induced sleep endoscopy. And right now, that's kind of how we're seeing where collapse might be.
Sure.
And then you've got the CBCT looking at different aspects. But I mean, this is an ultrasound technology, and it was pretty cool. But it's just what is coming, Mike, is amazing. So part of my presentation, is talking about the primary care dentist, the importance of collaboration with the ENT, the orthodontist, speech language pathologist, oral OMTs, oral surgeons, all of that, sleep physicians. But I wanted to talk about how is this new? What you're hearing is, people are getting on the airway bandwagon. It's the new trend, right?
Right. Fad trend.
It's
way
a
to make
fad.
Money, way to,
they're all
treat more patients,
expanding everybody, and just, and which is just not true. We're not expanding everybody and throwing devices at. That is not the case. We're just being more comprehensive.
And we may not even be expanding more people than the average orthodontist who does a lot of phase one and has no idea about airway, to be completely honest with
you. Good point.
Yeah, we may be doing less because we actually really go through detailed diagnostics to determine the best patients to do this on, as opposed to just like, they look a little narrow, or they're a little crowded. Most orthodontists approach this from a solely, as you say, the white thing,
mechanical,
right?
the white things.
Teeth, like look at all these teeth in there. Ooh, I don't know if I can fit these. Let's expand. I've had heated debates with colleagues who are pro phase one, who are pro interceptive treatment. In fact, in the community I practice in upstate New York, one of the practices that was most critical of my approach, it was a group practice. They were kind of pioneers in the upper lower expansion concept in the early 90s, well before that was in vogue. That was really outside the lines to be doing that. Yet when they heard I was doing it with braces and wires and taking cone beams and looking at airway, patients would come in for second opinions, and people talk in a small town, especially, and they'd be, they're saying this, what you're doing doesn't work. And I'm thinking, 30 years ago, I gave them a lot of credit for like pushing the envelope and saying, we're not just going to extract 4 buys on every case, but maybe we can help these narrow patients grow. It's not just, interestingly, I found orthodontists who are in this sort of dogmatic mentality of no phase one that oppose this. I have orthodontic colleagues who are really in favor of phase one, who, as soon as you mention the A word and go airway,
the A word,
they're like, nope. That's outside of our realm. So to the point of, a couple things I want to touch on. One is what you said about, is this new? Is this a fad? Right. We've talked before in our previous podcasts about some of the things going back. You said that when we talked a little bit before this about the Bogue reference. So I don't know if you want to start with that, and then I'll
just something I showed. I always like to kind of tease the audience a little bit, and I put up Bogue's reference of looking at the E's. Now, this is literally, this article is primary dentition.
Yep.
I mean, it's all about primary dentition.
Yep.
And he shows the discrepancy between primary teeth with spacing,
Yep.
primary teeth without spacing. And basically his take-home message is, let us not minimize that small, what appears to be a small discrepancy between spacing and no spacing, but get to the problem really of the why behind the change, which is really an etiology based. And the fact that it will not correct itself.
Right.
And so let's not wait till they're older. And then just deal with braces.
Yep.
And then my last slide is, this was a paper from 1918. And you can hear the audience just go, oh my God. You know, like everybody's like, what? You know,
over 100 years ago.
It's not new. It's not new. And so I feel like we're not doing what is new. Is we have the technology that basically supports what our colleagues that we're standing on their shoulders. It just supports what they were saying. They just didn't have the technology. And we're just coming out with the research and technology that's like, oh, well, then this is why. And look at these adenoids and look at, you know, but yeah, 1918.
Yeah. And to that point, I want to read something from 1928 from an article that Holtzman put out. Take about a minute here to read, but I think it's really important and profound to your point. There's a big thing that we face in this, and I'll come back to some of the responses I received to my part 2 of my article, which was called Expanding Your Reality, the article in Orthotown that talked about slow expansion versus rapid expansion versus doing it with braces and wires as I do it, and all of the biology of that, the chronology of that, timing it based on patient age and so forth. But
can we get that article outside of Orthotown?
Yeah, I can put a link. I can give you a link for.
Thank you. I'd love to put that in this. Yeah.
Yeah, I'll give you both part 1 and part 2. Part 1 goes into just kind of the first part of what we've been talking about, which is the need to diagnose and find the etiology. So part 1 goes into detail on that, has a lot of references of whether this is typically a tooth size problem or a jaw size problem. And then part 2 goes into a way to approach treating that with a couple of cases, showing how I treated it from start to finish with radiographs, slices of cone beams and everything on 2 different cases I treated. And really gives a brief overview. Obviously, it was limited in that type of forum on what I could provide. So Holtzman said, some of the more common causes of irregularities in the temporary teeth are enlarged tonsils, hypertrophied adenoids. Remember, this is 1928. Thumb and finger sucking, and faulty habits of tongue, lip, or cheek. Enlarged tonsils and adenoids prevent the normal action of breathing, with the result that the child's vitality is lowered and general development of the body is retarded. Any deficiency in vigor or growth is reflected in the positions of the teeth. The normal action of the tongue and cheeks, you're going to love this part, is in a great measure responsible for the shape of the arch, right? As you've called it, nature's expander.
Nature's expander.
Which I love, and I've stolen from you. I'm sorry. I credit you with it, but
I'm sure I got it from somebody else too. So whoever I got that from, I don't remember. But
when the mouth is closed, the tongue lies in the floor of the mouth, and the force of the atmospheric pressure sucks the dorsum of the tongue against the hard palate. This flattens the roof of the mouth. As the teeth erupt, the pressure of the sides of the tongue pushes them outward until the force is equaled by the inward pressure of the lips and cheeks. If these forces are normal, the teeth will form perfect arches. When these forces are abnormal, the arches are either pressed into abnormal form or they are prevented from developing as they should. In such cases, the teeth are irregular, not from their own activity, but as a result of the forces acting on them. In conclusion, when one can diagnose an arrest or lack of development in the temporary arches, treatment should be instituted to stimulate growth of the maxilla or mandible to obtain space to accommodate the larger permanent teeth. It seems, therefore, that it is good practice to correct malocclusions of the deciduous teeth at any age, when it may be done easily and painlessly, when by so doing, you enhance the possibility of the permanent teeth erupting in normal positions. 1928.
Oh my gosh.
Anybody who sits there and says that what we're doing, they label it as like orthotropics, or what do you call, like, I remember with my article, people were like calling it like orthotropics or different things, or I'm like, I don't even know what what are you labeling it as? What I'm doing is helping my patient in line with science and biology. Like, I don't care what you call it. I'm not into the name calling thing, but, and to that point, you don't have to do it if you don't want to do it. But which very great podcast that you just had on with Courtney Levine that I listened to, which was great. They really talked a lot about that side of it. And I thought you guys did an awesome job explaining, like, this isn't something every orthodontist has to want to do, but my gosh, stop trying to basically gaslight and say that this isn't a thing and has never been a thing and is kind of a new thing that this little cult group is doing to just generate revenue for their practice. It's false. And I'm not going to sit by and let that be how people like you and me and our colleagues who are passionate about this and know what it can do for our patients get labeled that way.
I'm so glad you read that. And that is, it's super powerful and it's to the point and it's true.
Right.
It's fact. Right. So and this isn't like our opinion.
Why do you think in 100 years, we knew this 100 years ago, a few less than that, but 95 years ago, we knew this. Why how has it that fallen by the wayside, and the opposite approach, which is don't do this young, prevailed?
That's a really good question because, it's when I just did a workup on a 4-year-old.
Okay.
Last week, and I'm doing basically an Invisalign workup on him.
Yep.
And, the mom is completely on board. And I find that, I just plant seeds. I talk to the parents. And she used to be a CPAP. She used to work in the CPAP community.
Wow.
So she understands airway, and she is like, sees exactly what's happening in her son and knows what his trajectory is.
Yep.
So she's like,
and we'll do basically anything to
avoid that.
Going down that path. Yeah.
Yes. So am I saying that, my, expansion and uprighting, of his arches is curing anything? No, but I'm a piece of this puzzle.
Thank you.
For this child.
Right.
And I'm going to give him a myo-munchie. I'm going to help stimulate while we're doing some of this uprighting. I'm going to give him a myo-munchie. We're getting back to the ENT. This kid has had his adenoids out twice
at 4.
Yeah. And he's still mouth breathing. So we are going to they just moved from another state. So again, maybe allergies, maybe new allergies.
Yeah, we were
hit.
talking before in full disclosure. I'm dying over here with allergies. And
poor Mike.
It's but I get it. The allergies can really have an impact. And why aren't we? Kudos to you for recognizing that and getting him. But why are why are? But most of us
why?
not?
So your question was like, what is going on? And I guess when I get together with other people like us, we're sitting around, at courses, and we all go to dinner afterwards. We have these conversations. What happened? And it's like, sometimes, is it an agenda of organizations? Is it political? Is it money? It's faster to do it this kind of, what am I trying to say? Like assembly line, it's like the model
doesn't fit the model.
It doesn't fit the model.
It doesn't fit the model.
How did we come up with that model? And it's like, I think one thing happens and then another thing happens, and it's a slippery slope.
Yes.
And then we get into this paradigm that we're in right now, and this mindset and this model.
And you get a few loud voices that come out against this, Tunkay, Gianelli, that there's no value. There is no benefit to interceptive treatment. I mean, again, those statements just blow me
Ugh.
away that you could
Yeah.
say that. But as we know, lies, damn lies, and statistics. You can conduct a study to basically show whatever you want. I have my
Exactly.
master's, been involved in master's level research, work with residents on their projects. I see what happens in the formulation of these ideas in these studies. They are constructed for certain purposes. And then you add in corporate money backing them and ulterior motives and wanting to get them published, right? And if the journal you're going to try to get them published in really doesn't agree with that approach, well, maybe you're not going to push that envelope. It's interesting as I've looked through the literature on this many, many times, I noticed just in literature in general, I found like in the 70s, even the 80s, you would see studies run by academic institutions, orthodontic residencies, say, and there would not almost always, frequently be involvement from private practice orthodontists listed in those references, right? So you'd see, 5 names, 6 names, and the first 3 or 4 would be, maybe the first two would be faculty or director of a residency, maybe a couple residents after that, and then 1 or 2 private practice orthodontists who were participating in these studies. I rarely see that now, period. Actually, I don't see a lot of American orthodontic residencies putting out a lot of good research into the AJO-DO really at all anyway. There's very little. Most of it's coming from abroad. So what are our residency programs doing that they are not bridging that gap between private practice and academia? And I think that's a big part of it because both need to be there. We need both. Both have profoundly important roles. But academia has kind of set this precedent that if it's not born out of research in academia that we say at this current time is valid, then it shouldn't exist clinically. And clinicians, private practice, wet finger orthodontists, or primary care providers who are doing the interceptive treatment, look at it and say, you're an ivory tower academician. You don't know what it's like to practice out there in the real world. You've never been in an office, seen 100 patients a day and understood what it really takes to do this efficiently and tried new things. You're still doing it the old way. So let's just break that down. What is the old way? Well, the old way clearly is not what we think it is, which is 4x extractions. And that's what gets labeled as kind of the old way, right? Old school, like they're just going to pull teeth. No, that's not really old school. We knew 100 years ago that really wasn't what we were supposed to be doing in every case, right? Not never, but rarely, because as they have said multiple times, I have another reference I'll read from 1949 in a minute. But we've known for a while that that's not so that's not a new thing, like that we should be helping grow arches and develop arches. What's happened is academia, I feel, because I'm very involved in it, doesn't get the opportunity to get these patients at 4, 5, and 6 years old in an orthodontic residency. In fact, many orthodontic residents don't even treat a phase 1 while they're there. Many of them don't learn how to analyze cone beam. Many of them learn nothing about airway. So academia has fallen down this path where they are myopic and they have blinders on and they won't look outside of their tunnel vision. Okay. Then you get private clinicians who are all in a lot of us are in that outside lane, right? And we're looking inward going, they don't get it. So basically, and this saddens me greatly as someone who's been through a lot of years of school and is very involved and has been at teaching at every level of post-grad orthodontics and dentistry. It saddens me that there is this divide, and almost what residencies have become is this sort of get through it to get your degree, and then you'll learn how to do it on the outside. Nowadays, orthodontic residencies, they're paying 50, 60 grand up to 100 grand a year paying, not getting paid. They're not getting the GME money that a lot of other residents get out there. A large number of orthodontic residents are paying anywhere from, say, $30,000 to $100,000 a year for this education. They're going into tremendously deeper debt for this, just so they can learn things that they have to unlearn or relearn when they get out to do it in the quote unquote real world. So I really think we need to call for academia and private practice to start to get together. Now, last thing I'll say about that, and I want to hear your thoughts on it. Sorry to rambling on this.
No, this is great. It brought up something in my mind too. Go ahead.
Okay. So the last thing I'll mention with that is, I think maybe say, well, why did that happen? Why did there used to be all this research that was happening between private practice and academia? I don't know when the IRB really came about. I should have looked that up, but the review boards and committees that review these studies. So as I've tried to work with residents over the years on certain studies to analyze some of my data and try to provide data to substantiate what I've been doing clinically, it's really hard to figure out how to merge my private practice, HIPAA, and I mean, HIPAA was what, 90s, early to mid 90s. So
90s.
if you look at the literature, I bet, this is just kind of my own hypothesis, I bet from the time HIPAA came out, you're going to see a steady decline in the integration of academia and private practice from an educational research standpoint. And I think that's really, really, really hurting the profession, because it's making us not work together on these projects. Because just to get my patient database or my patient records into an institution, make sure they're safeguarded, make sure they're encrypted, make sure then who can access them. Logistically, it's not super easy to do.
No.
And so what happens? Clinicians and private practice docs do what they do. Academicians do what they do. They spat and go back and forth on one another over who's right and who's wrong, and who suffers? The kids that don't get the treatment they deserve.
Yeah, 100%. There is, gosh, I'm going to have to find this. My partner in ASAP, Tracy Wen, she posted this link on Facebook, and it's this man talking about evidence-based and how he's just watching really intelligent people go into academia and then come out less intelligent than they came in, because they're throwing out their brains. They're throwing, and he said, really, where change comes from is not academia. It comes from the fringe.
Yes.
So he said, for instance, the light bulb never came from all the candle makers.
Right.
Candle makers didn't invent the light bulb.
I love that. Yeah.
So it came from the fringe. Right. So that's where change is going to come from. And gosh, if I can find that link, I'm going to throw it in this podcast too. But
and then you need academia to take that fringe and investigate it.
And investigate the fringe.
To provide, like what you were saying, Audrey's doing at Stanford. Like, you need to take the fringe and look at it and break it down. And that's not happening. Stacy, they're afraid to even, at some residencies, they're afraid to even use cone beam in evaluations of data for master's level research. I mean, like,
why is that?
Dogma.
Oh.
Not the way we always did it. We use Cephs. We analyze off of Cephs. There's no standardization.
Gosh, what you can see off of a CBCT
it just saddens me so much. It's like, talk about head in the sand. I had a podcast just released yesterday, but by the time our podcast is released, it'll have been a few weeks. So mid-December was released with an embezzlement expert. And he talked, it's actually a great episode for any dental practice owner, employee, about embezzlement. David Harris runs a company called Prosperident. He amazing, fascinating guy. I mean, I could have talked to him for hours. And one analogy he used is, a lot of dentists, when it comes to this embezzlement stuff, like to stick their head in the sand. And he goes, the problem is, it's not any better when you pull your head out. And so I feel like that applies to what we're talking about as well. A lot of people are trying to kind of stick their head in the sand when it comes to the airway side of things, and hope it just kind of goes away, give us put enough arrows in our backs that we're just, not going to take it. The thing is, I think now they've kind of self-selected for a pretty tough group of us who are fighters and who aren't just, I don't really care about the arrows in my back, really.
Right.
I'm going to keep fighting. And so it's going to take a lot more than that to stop me from getting this message out. I know you feel the same way as people like Audrey and Rebecca and people we've spoken about. So, and tremendous credit to Maz for putting that forum together. And this is what has to happen. But I think we need to do, I can honestly tell you that I've never seen a greater divide. I've been involved in academia either as a resident or as a faculty member since going on 25 years. I've never seen a deeper divide between academia and clinical practice than I've seen today.
It's just a shame. How can we be in 2023 and that's the case? What were you said you had another paper from, was it the 40s?
49. So this is really interesting. This is 1949. Weber published an article titled, you're going to like this one, Prophylactic Orthodontics. Okay.
I love it.
Prophylactic Orthodontics. And this was published in the AJO, which, for those who aren't aware, the AJO-DO was the AJO until I believe like the early 80s. It added the DO in. So same publication as is the AJO-DO today. This was presented in partial fulfillment of the requirements for certification by the American Board of Orthodontics, read at the meeting of the American Association of Orthodontists in New York, May 1949. Okay, so this was done as part of the requirement you had to do back then for board certification. And it was at the AAO meeting in May. So coming up on 75 years this May. It talked about the fact that colleagues often shun those who believe it's possible to prevent the development of a severe malocclusion by intercepting when the patient is young. So it acknowledged in this position paper that there is this sort of stigma against orthodontists who are out there in 49, who are out there saying that you should be trying to treat patients when they're young. And
Really?
all that's old is new again, right?
Here we are.
It said that we should carefully consider the probable results of extracting primary or permanent teeth before we recommend the removal. It's what you and I have been saying, right? Diagnose. What's the etiology? They've known this for a long time. We've known this. Our profession has known this for a long time. And Weber went on to say that extraction of a primary canine to relieve crowding in the permanent incisor region is, wait for it, rarely indicated. Said, and I quote, "The complication that arises out of this procedure is one born of the short-sighted policy of extracting 2 teeth to make room for the eruption of 1. Said we should instead be focused on breaking oral habits at the earliest time possible, including digit sucking and tongue thrusting." So they were starting to understand, even back then, the role. I mean, we read from Holtzman in 28. He had about the atmospheric pressure in the tongue. And we're just finding studies coming out now showing that maybe the reason adenoid hypertrophy returns in patients who have had an adenoidectomy, with or without tonsillectomy, and we have these recurrent adenoids growing, maybe has something to do with the atmospheric pressure and the fact that they're not getting that pressure to push that air through the nasal passageway into the nasopharynx, and that is allowing the adenoids to regrow. So they were talking about this 100 years ago, and then the AAO, which will be the 75th anniversary of this presentation coming up this May, who now seems to be, I don't want to say running away from, because I give them tremendous credit for they're having next year, the winter conference is going to be on this more topic of pedos and orthos together talking about interceptive treatment. I give them tremendous credit for that. I really, really do. I know it's hard when I had Myron Guyman, the AO president, on a little while ago on my podcast. And one of the things we talked about was it is hard when you're a governing body of this many voices.
Yes.
To really, number one, not upset some people. Number 2, please everybody. And number 3, stay within the confines of the law. They are regulated pretty heavily by what they can and can't say. So I get that. And I get that change is slow. I think what's happened is there are some loud voices within that arena who have really stolen the microphone. And I think casting stones at the AAO, to me, is kind of short-sighted, because the AAO, I mean, look, they were open to talking about this 75 years ago, right? So I don't think it's like, the AAO just isn't that. I think it's just leaders change over time, and people that run committees and run the educational committees and determine who's going to speak at what lectures and presentations are going to be the ones that are there. Things kind of go through phases. And right now, we're in a phase coming, I feel, and I want you to talk more about this, coming out of a phase, because I really do feel like we are getting there, but kind of beating that door down. But they were in a phase where it was like, again, the 90s articles by Tunke and Gianelli and these really loud voices within the profession who were just like, no, interceptive treatment, bad, never really a place for it. It's just charging the patient twice. And those articles were put out quite a bit. With now, we're starting, those voices have kind of faded down a little bit, and you're starting to see these newer voices come up and say, no, wait a minute, there's a place for this, and we're going to get at it. So I'd love to hear your thoughts on that.
Well, what you just said, I have heard that. Well, we might have to charge for 2 expanders. And, Tracy actually just put, Tracy Wynn had a really good video on those that follow her on, that follow her on Instagram. There is someone around her that is beating the, I don't care about airway drum or whatever. And so she gets a lot of the patients from that office. Anyway, and
you don't have to say the name, please, but is it ortho or
ortho?
Ortho. Okay. Right.
Yeah. And she has a video of basically kind of like and not an anatomage. It's not an anatomage. She names the software that she uses, but it's basically a rendering of her CBCT. It has the face and all of it on there, and it shows this very retinopathic child, and they just want to wait because they don't want it to be too expensive. I mean, just different things like that, that the parents are like, please help my kid. So this kid's on CPAP. It's horrible. He needs class 2 correction. He needs expansion. He needs possibly, here's the thing. He's on CPAP. So like what Tracy's point was, I'm going to use protraction mask with this child, not to necessarily protract, but to keep the midface from being damaged further from the CPAP. So the child is going to stay on CPAP because he needs it to breathe while she's expanding, while she's advancing the mandible.
Interesting. Sure. Yeah.
And so then she's using the protraction to keep, because those that aren't familiar with nasal CPAP, it looks like headgear. So it's a mask on the nose and a strap that goes behind the head. So it's preventing growth of the maxilla.
Yeah, it's tight. It's got to have that pressure.
It's tight. It has to have the seal.
Positive pressure.
Right. Yeah. So she's using, and she's done this to get kids off CPAP. So they stay on either their AutoPAP or CPAP while she's expanding, bringing the jaw forward, and then we can watch those pressures decrease as the mandible's brought forward, as there's transverse expansion, and hopefully get the child off CPAP or a minimal pressure. But she's minimizing the deformity that could happen from the nasal CPAP.
And even if she maintains where the patient's at, it's still
positive. Exactly. Because it would have, exactly. It's neutral, at least airway neutral and not airway negative. So, but we were just talking about, I digress because it's people are so worried about charging possibly twice for an expander, worried about the parents' benefits. And
was that the only argument this orthodontist was making against it?
I really don't know. There was something about finances involved, and they didn't want it to be so expensive, and they were going to wait on things. And so the parents were like, please help us. And I use this slide in my Winds of Change. I actually put up a slide. I have a little bitty 3 or 4-year-old that has a set of glasses on. And have you ever seen those little kids with glasses and they have the little strap because they're so little, their little glasses they're going to fall off. So they're walking around with their little strap on glasses. You would never hear an eye doctor say, well, let's wait till you're older to get you some glasses. Then I have another picture of a child with a hearing aid in, and he's about 3 or 4. And you would never, medicine doesn't do wallet biopsies on patients.
Right.
They don't do wallet biopsies. They look at a child in need and that have sensory deficits and issues, and they say, this child can't see. This child can't hear.
Right.
And even,
and we're just going to kind of wait on this.
Watch. Wait till they wait till they're done growing. So they need less hearing aids.
Right.
I mean, or
that's such a
less
good point.
glasses.
Right. You don't want to have to pay for 3 sets, like 4 sets of glasses.
Why would we want you to have 3 sets of glasses? Let's wait till you're like, your head's done. Maybe let's get you a set when you're 7 or 8.
And where did that start in orthodontics? That like charging, if you're doing something, I get it if you're doing nothing. And exactly. But I would actually contend that a lot of people who are just like pulling primary teeth and putting space maintainers in or doing all this sort of stuff, they're almost overcharging in a sense, you could say. I'm not pointing to any one particular modality, but to say that that's okay, but then say that doing it maybe a little younger with a different modality is overcharging. It's like, wait a minute. So you're doing something the way you're doing it. And that's fine. You can do it your way and charge for space maintainers or whatever the case might be younger if that's your approach. But if I go in and charge for my approach, I'm overcharging.
And it's like, look, we are doing something. We're not charging for nothing.
Exactly.
We're charging for a procedure. And this procedure happens to be on a child that's younger, and they might have it again. And, something too, we don't know if this parent's going to go get a new job with new benefits and I don't have a crystal ball. All I know is there's a child in need in front of me. And supervised neglect is just not what I'm going to do.
Right.
I'm not going to sit and watch a child suffer. And we have too much research out with the ages of between 4 and 6, knowing with the Karen Bonnick study, the David Gazal study. I mean, the Karen Bonnick study was 11,000 children,
Yep.
no PSGs. This was mouth breathing and snoring. And then the behavioral deficits, the behavioral changes. They watched 11,000 children between 6 months and 69 months old, and then looked at them at 4 and 7 years old and the behavioral issues they had. And it was like unprecedented. Like, it's an amazing research paper that is a wake-up call to our profession of, thank God for the primary care general dentists. Because if the orthos do not want to see these kids at 4, 5, 6, thank God there are. So please don't, get angry or throw arrows at a general dentist that is, I don't
But don't you think, sorry, Professor, but don't you think that might be why they're throwing the arrows? Because they don't want to do it. And part of it comes out of ignorance, and it's that, head in the sand, right? I just want to stay the way I do it. It works. I have my systems. My staff is trained a certain way. Because as I've said before, when I switched to doing this with braces and wires young versus doing expanders, and even when you do expanders versus extracting a lot of teeth young, it requires a totally different level of training and systematization and scheduling and inventorying. It's a change. And when you're a busy orthodontic practice, been doing it one way for a long time, and you're not directly seeing that you're harming the health long-term of your patients, you can easily put your head in the sand and remain ignorant and be like, I can't do anything about their breathing or their sleeping. I'm the orthodontist. I treat the teeth. So it's easy to remain ignorant, number one. And number two, they're fearful that someone else is going to do it. And if if you were to just if you step back and think like the orthodontist would think, right? As an orthodontist, we think we need to get that patient in our practice, right? So that they want to come to us when they're ready for treatment. Well, try to think for a second what happens if and when the primary care dentist, be it a GP or a pediatric dentist, starts treating that kid at 3 or 4 for some stuff. And we're not set up to do that. We don't really know how to do that. We definitely didn't learn it in our residencies. Now that's a threat to our entire profession. Now that's a threat to our patient base. We already have primary care dentists who are doing Invisalign and treating some of the adult patients that we treat, right? Now we have it on the other end where they're taking our pediatric patients and they're not sending them to us. And we start to say, I need to throw arrows to knock this whole thing down, because if I don't, in 10 years, orthodontics will be obsolete. Instead of looking at it and saying, why don't I start to think about what I don't know? Why don't I start to think about, let me talk to these people. Let me see some of the cases they've treated, right?
Yes.
The online forums and the orthodontic study groups, that some people were throwing some arrows about my cases I showed in that OrthoTown article. You know what I find? What I said, I didn't get in a back and forth sort of tit for tat, because I was like, it devolves on social media, especially.
It does.
Those conversations need to be had face to face. It doesn't work to do it on social media. So what I decided to say was, instead of trying to go point for point on things, I said, you know what? I said it to both of them. I said, I want you to tell me, you can label what I did however you want. You can mock it. You can say whatever you want. I want you to show me one, because they said I was cherry picking cases. And I did explain, like, this is an article in a journal. I can't, like, 2 cases as I had to push it to just get 2 cases in. And I thank Chad Foster and Sam Middleset at OrthoTown for allowing me to put 2 in, because I know for them that adds a lot more publication space. But what I try to explain is, I could show you hundreds of these, right? And I could. And so I made an offer, set up a Zoom call with me. We'll sit down together. I'll take as long as you want, and I'll go through case by case by case by case of times I've done this exact same thing I showed in the article. And number 2, you just show one case that started in a similar situation, comparable to one of the patients I showed in that article, that you treated to a superior outcome. Because in that article, I didn't just show the phase 1. I actually showed one didn't even need phase 2 and one needed phase 2. And it was like 12 months, very straightforward. I said, So show me a patient that started where those patients started at 7, that you used your approach and got a superior result 6, 7 years later. One. One, if you're going to make these claims, put your money where your mouth is. Show me you're doing it better than me. Neither of them took me up on my offer. And I offered for like one crickets. Time. I said, I'll tell you what, I'll do one better. We'll record the Zoom call and I'll publish it on this forum. I'll publish it. All you've got to do is bring me one case. And they just kept, again, kind of throwing arrows, trying to.
Yeah.
And again, no one, I put that challenge out to anybody. Take some of these cases that we show and show that they did it better. And if you didn't, I'm not saying you need to do it the way I do it. Honestly, I am not. What I'm saying is, what ground are you standing on to mock the way that you or I do it? Right? Like,
it's so interesting that it's funny. I love how you said, we just all need to be open to how we could be wrong. And when I was talking to David McIntosh, Dr. David McIntosh, he is an ENT out of Australia. Mm-hmm. He said, I don't want to be right. I want to do it right.
Yeah, I love that.
And he said, I go into situations asking, how could I be wrong? Mm-hmm. How could I be wrong? And if we all did that approach, how mm-hmm. could I be wrong? Mm-hmm. And be open and listen to each other. And it's not about who's right. It's like, let's get it right.
Let's get it right.
Let's get it right.
Yep.
And I really like that. And that's what you were alluding to. And it's really interesting to me how, here's another pushback from some orthos I've heard. They're mm-hmm. like, just because you're intervening, okay, great, Stacy, we're not saying don't send a kid at 4 to the ENT. That's not the issue. Mm-hmm. It's what they have issue with is that I am now putting Invisalign trays in a 4-year-old and creating this broad arch mm-hmm. At 4. Mm-hmm. When they're like, that's really not doing anything. It's the right. ENT that's doing something.
Right.
You're correcting the malocclusion isn't necessarily. We don't have any research saying that's doing anything.
I was just going to say, show me the studies that.
Show me the studies that when you do that, the airway improves.
Yeah, well, they haven't been done. So how? Show me exactly. Show me the studies. You know what I say to that? Show me the studies that show that it doesn't work. Yes. How about we flip this table back on them? Yes. Okay, you're going to be so quick to want studies that show it does work. You show me data that shows it doesn't work.
Show me all the 4-year-olds where it didn't work.
Right. Because you can't have it both ways. You don't get to say this doesn't work and there are no studies and then not do the studies or call for the studies. You could flip it 180 degrees. Again, and the converse of that just simply becomes, you prove to me it doesn't work, because I have lots of cases. At least I have empirical data that it does, right? At least I have anecdotal data, volumes of it.
And this is what I wanted. Does. Exactly. And this is what I've got to find this, he's an amazing, he's a scientist. He's wonderful. And just what he says of, academia is not evidence-based. That is not what evidence-based is, not just academia.
It's not just
if anything, it's a lot of times you come out of academia sometimes less intelligent than when you went in, and you've lost some of your natural troubleshooting and your logic. And but
it's a bit of a brainwashing in ways.
Exactly. And he said, anytime, academia puts out a paper and everyone agrees, and peer research papers sometimes are just basically everybody agreeing on one thing, which can be, is that necessarily the best thing either? So it was a very interesting talk that he gives. But, when you logically have to look at, and anecdotally, empirically, the shape of this child's dental arches, he actually has crowding of his lower anteriors at 4. Mm-hmm.
Which we've known for 100 years
which we know is
not what should happen. Right?
Even just straight, no spacing is a malocclusion. So he's beyond that. Right. So I am trying to what I want to do is get the child back on track where he should be for his age.
Right.
That's what I'm trying to do.
Right. And you're not expanding to solve his airway problem. You're expanding because he has narrow arches.
I'm expanding because he had an airway problem. It caused a malocclusion. He has no room for his tongue. I'm trying to make room for his adult teeth, make room for the tongue, make that palate look more like the tongue print it should. It looks like a V.
Yep.
And I'm trying to get the child back on track to where he should be for his age. He's behind craniofacially.
And how does someone criticize that? I mean, truthfully, if it's your kid, like that's what I say to people too. If this is your kid, and we can finish up in a couple moments here with maybe a story or two about some of the kids' lives we were able to change. But if this is your kid, right? What would you really say? Don't do anything. I don't think there's studies that say when they say, I could give them some Invisalign or some braces that would, really, it's only going to help. It's not going to hurt.
I'm making room for the tongue, a better posture for the tongue. We might need to include some myofunctional therapy because we've had nasal disuse for so long.
Yes.
We've got muscle atrophy in places we shouldn't and hypertrophy in places we shouldn't.
So well said.
So we got to get this kiddo. It's like physical therapy for the craniofacial structures.
Right.
And what Kevin Boyd, Dr. Kevin Boyd, pediatric dentist in Chicago, craniofacial respiratory complex is what he calls it.
Okay.
The CFRC, craniofacial respiratory complex.
Okay.
And this is what we're trying to help.
Yep.
So, and like you said, if it's your kid, would you just sit by and just glasses, hearing aids, growth and development of the face, of the airway above the palate, the airway behind the soft palate.
Right.
And it's my friend and colleague, Dr. Susan Maples, who I'm going to have her on next year on a podcast. She has her own podcast called The Brave Parent. Boy, we're just plugging everybody. But we need to plug each other because there's so much to hear.
We have
to. She has a podcast called The Brave Parent. And I love, oh my gosh, such a dynamic speaker. And she talks about, she actually spoke at ASAP not too long ago. And the title was, My Kid is Pooped. And what does their poop have to do with it? So she goes into the gut biome and the relationship between sleep health and airway health and the microbiome. But she says there's no such thing as somebody else's child. And I love that. The second those kids walk in our door, they're our responsibility as well. We are an adult in their life, and we have to intervene if we see them struggling.
And a medical provider at that.
Yes.
An adult and a medical, where they're trusted.
And a provider.
Where they're trusted medical dental healthcare provider. And two things on that. One is with the gut. I was listening to a podcast earlier this week, and it was a gastroenterologist talking about his training, and he is big on the gut microbiome. And as I think anybody out there listening who's health conscious or has started to understand, well beyond the scope of this episode to talk about why and our gut microbiomes are changing so much, but he's big on this. And he said, and I was listening, I literally rewound it and listened to it again. Cause I'm like, did he just say what I think he said? He said in his residency training, he took a 2-hour course, 2 hours, the entire time on nutrition and gut microbiome in his entire GI residency.
Unbelievable.
And I went, oh my gosh. And this was actually ironically as I was driving over to teach it at the residency, and I was in the car and I'm like, and I was going to be talking that day about airway and CBCT and all that. And they don't get any of that outside of from me. And I'm going, oh my gosh, this is a fundamental problem between academia and clinical practice.
Practical. Yes.
Right. It's not actually like ortho dental. This is a problem in all of medicine right now. Is the research is not keeping up with how quickly we're learning in real life practice. And again, the need for the path of both of those. And then the other thing that triggered was my last thing I'm going to read today is the ADA. So when we talk about practitioners who you'd mentioned, Tracy had someone who was critical of the way she was approaching it, right? And they kind of accuse us, it's thinly veiled, but like almost malpractice, right? It's almost like you are doing things you shouldn't do because charging for a service that you shouldn't provide is malpractice. Again, they're not coming out and saying it, although I guess some are, but they're basically, their point is that you're doing things you shouldn't be doing to these patients, right? The ADA, their position statement in 2017, titled The Role of Dentistry in the Treatment of Sleep-Related Breathing Disorders, or SRBDs, which encompasses adults and children. So I'm just going to highlight a couple points that deal more with the pediatric population. But before that, they define sleep-related breathing disorders, which again, I'm big on getting into the sleep disordered breathing over the OSA. I think when we go OSA, We call in.
It's too small of a niche.
Yeah.
It's,
and I'm big when I lecture. I talk a lot about the difference in those, but there are disorders characterized by disruptions in normal breathing patterns. SRBDs are potentially serious medical conditions caused by anatomical airway collapse and altered respiratory control mechanisms. Common SRBDs include snoring, upper airway resistance syndrome, and obstructive sleep apnea. So again, OSA is just one part of this bigger scope of breathing disorders. And then it goes on to say the dentist's role, this is the ADA, is saying the dentist's role in the treatment of SRBD includes the following. Dentists are encouraged to screen patients for SRDB as part of a comprehensive medical and dental history to recognize the symptoms such as daytime sleepiness, choking, snoring, or witness apneas. These patients should be referred as needed to the appropriate physicians for proper diagnosis. So right there, any dentist or orthodontist who isn't looking at their pediatric patients for these issues is technically out of line with the recommended guidelines.
With the guidelines.
Secondly, in children, screening through history and clinical examination, something orthodontists tend to rush through, that initial evaluation, may identify signs and symptoms of deficient growth and development or other risk factors that may lead to airway issues. If risk for SRBD is determined, intervention through medical dental referral or evidence-based treatment, which certainly expansion is well within evidence-based treatment, may be appropriate to help treat the SRBD and or develop an optimal physiologic airway and breathing pattern.
That's our ADA.
That's our ADA in 2017. So
you said that at the Winds of Change. I brought those guidelines up.
No way.
I did. I brought up the guidelines.
It's crazy.
You and I just are vibing on this thing because I wanted them to understand this isn't my opinion.
Right.
These are the guidelines from the American Dental Association. I also showed that the American Academy of Sleep Medicine discusses the role of dentists. Now, granted, it's for adult OSA, but we're still talking about an anatomical issue. My point was the AASM says dentists are needed to collaborate with for CPAP intolerant patients, mild to moderate apneic patients to stabilize that airway.
Right.
And I show a self-extracted from CBCTs from a 9-year-old to a 16-year-old to a 37-year-old, and they all have the same small dysfunctional, what are you going to do? Right. Here we're doing CPAP. Here we're doing oral appliance therapy, mandibular advancement devices, MMA surgery.
Maximally invasive surgery.
We have the same problem in a 9-year-old. What are you going to do? So then I show the ADA stand.
Yep.
What the ADA says.
Brilliant.
Now let's talk.
Yep.
So, this isn't, it really is the squeaky wheel, I know, gets the oil and when you've got a few loud voices, but we just need to keep all doing what we're doing and what we're seeing in our practices and doing the right thing for our patients. And the research that is coming out is really very much in support of what we're doing. And I think we're going to, what my prayer is that our podcast, maybe Mike, in 2 years, we'll have to find something else to talk about because it's so mainstream that we'll move on to something else,
Agreed.
But right now it's educating dentists, orthodontists, medical colleagues.
Yes.
And I hope people take this podcast, share it to your patients. They deserve to know this is an option.
I completely agree. Yes, they deserve. But I think, again, the dental ortho community, a lot of them don't want the patients to know this is an option. That's why they're so critical of it. That's why they mock it when a patient goes for an opinion with someone who we were saying Tracy's approach, and then that patient say goes to an orthodontist, and the orthodontist just instantly is like, there's no place for that, right? It's right. They don't want it to be known because then maybe they're going to have to open their minds and eyes to doing it. It's much easier to change, and change is hard. So
change is hard.
To close, do you want to give me something and just a feel good story, and then I can give you one about
I've had just again, these little kids. I have a little girl, little Judith, and she came to me at 3.5 years old with a crossbite, and you can see her chin's off-centered, and It's a unilateral crossbite, poor sleep. Her sleep questionnaire, the PSQ, she was tired. She's not healthy. She's not doing well. We had sent her to an ENT, and they said, we're not going to do anything with the adenoids and tonsils at this time. Keep an eye on some otitis media, but they're like, Stacy, you do you. So I went ahead and corrected the malocclusion. I started right when she was 4. So probably 8 months in, we got her out of this crossbite. So now instead of her growing in this unilateral, uneven TMJ health, I made room for her tongue. We talked about proper swallow. And I mean, her PSQ, all her mom's like, she's doing so much better. I mean, we just see this every day, all the time. And it's like, mom's stoked. Yeah. I mean, and these kids, they move so easy when they're little. They're like, I think Mariana Evans coined the phrase, they're so juicy.
Yeah, really.
They're juicy.
It's just so easy.
They're so easy. And it's like, it's just, I just want to get them back on track. She had a hiccup with her growth and development. Let's jump in. So yeah, she's doing so much better. And we see a lot of these little Judiths. I got another little kiddo. Like I said, he's 4 years old. We're getting started on him. I'm not waiting. He's behind.
Yep.
He's already got a malocclusion.
Yep.
So I love to hear some of yours.
One that I tell sometimes when I lecture, and on my website, I have some testimonials that if you go to the website, the Ortho Coach, there's a testimonials tab, and there are literally parents. I literally just took my phone out and I just decided, I wish I did it earlier. It's one of those things. It's like, I didn't think of this. But anyone listening out there who does this, do yourself a favor. And when you get a parent starting to rave or break down in tears or all these things that we see happen all the time, when you do this, just say, is it okay if I just take my phone out and record this? Because I want to help other kids and other parents know about this, and this will help speak to them. So I started doing that later than I wish I had, but I would just be like, when a parent would raving, I'd be like, can I just record that? And so I've got a bunch of those on my website, but one that, what is really interesting was it talks about the power of doing this differently. So I had a patient come in, and it was Halloween. It was 6-7 years ago. And we had dressed up as different Disney characters, and I was Gaston, and I'm fully dressed. Like in my lecture, I show a picture of this. And so, it's a fun, lighthearted day in the office, but very busy. And so I get over my ear from my TC, like, hey, Dr. Mike, can I talk to you? You got a spot I can say? Sure. What's up? Mom of the new patient is here, and mom and dad, and their mom is adamantly refusing us to take a cone beam. She says there's no way she's going to do it. She said this is her third opinion. She's already had x-rays taken, and she refuses to have any more taken. Okay. I'm like, so, and that happens sometimes, right? People, because when you do a cone beam and people had another opinion with a pan, or sometimes they didn't even take a Ceph, but if they took a Ceph, you'd be surprised, by the way, how many orthodontists don't take a Ceph at part of the new records. Yeah, very often. So they took a pan and or Ceph or whatever it was. So my TC been with me for a while. She knew how to handle this. She knew how to script it, the importance. So she'd already been through with mom. It's a low dose image. It's less radiation than the Panorex. It lets us see things like airway, such and such. Mom was tough, not budging, right? Not budging. So I'm in the middle in the clinic, still doing some stuff here and this in my ear. And I explained to my TC, this is, try this, try that. She comes back on. She's like, nope, mom refuses. She said she knows she needs upper and lower expanders. She's had 2 opinions on that already. Back to my point that even orthodontists who are interested in doing phase 1 disagree with the way I was approaching it. And she just wants to know what our price is going to be for the expanders. So I said, okay, put her in the consult room. So I walk in dressed as Gaston. I go in this room, and I mean, mom looks at me like I don't know if I've ever had someone look at me with such disgust.
Like, who are you?
Like, really? This is who's going to tell me you need to take x-ray on my kid? Dad's just sitting there looking at me. Molly is the cutest little thing in the world. And she's just sitting there, and I look at her face. And Stacy, the face I saw. Yeah. Right. It was, maybe if you want, maybe I can send the pictures for yours. I'll put them up for mine. I'll just put her pictures up so you can see this kid's initial malocclusion in face in the podcast. dark allergic shiners, kind of like with my allergies
like
now.
you right now.
Yeah, like the venous pooling and just open mouth. And I look at her and I'm like, so I said to Mom, I said, tell me a little bit about why you don't want, I understand Missy's explained all this stuff about the x-ray and what questions do you have? Well, I don't see what the point of this is. This is ridiculous. You just want to do this so you can charge us more and so forth. And I said, okay, let me just explain a little bit. Let me ask you some questions. And I said, does Molly snore? And Dad goes, yeah. Molly breathe through her mouth like she has her mouth open right now. Is that how she usually is? Yeah. She restless sleeper. So I started going through the questions. All of a sudden, you start to see them going. And I'm like, I do things differently here. I said, I understand you've been told that she just needs expanders. I said, and I'm not saying she doesn't. I said, all I'm saying is I want to know why. And that 3D image for very low radiation is going to help me understand why. And if I need to send her to one of my medical colleagues, if there's something obstructing her breathing, I can't tell that from the 2D images that you have brought here from the other office. It was just a pan anyway. It was just, I can't tell that. I said, so I have to tell you, if you won't let me take that image, I cannot treat her. I said, because I am big on treating the cause of things. And if I don't want to just treat the symptom of her crowded teeth. So I said, I'll let you think about it. You guys talk about it. We'll step out. I'll have my TC come back in a minute or two and see what you want to do. So I leave. And over my earpiece, Missy comes on and goes, they're taking the x-ray. So I said, okay, good. Stacy, this girl couldn't breathe. She had complete obstruction of the nasopharynx with 90% with the adenoids, huge tonsils. And so I went back in the room and I showed them the 3D on the airway tour I take all the patients on, and I showed them. And I said, the first thing we're going to do is send her to the ENT, and it's going to change her quality of life instantly. And then I'm going to go in and I'm not actually going to use expanders. I said, that's fine. I said, expanders would work. I said, but I have a way that I feel works better. And that's just going to be braces and wires. I said, and in fact, one really nice part about that is if you can't get in with the ENT for a while, because the ENT I worked with was way booked up. He was so good. And I said, we can still start the braces, because ENTs don't love operating with a mouthful of expanders.
That's
but
right.
A mouthful of braces really doesn't make a difference to them. So we can start our part. And then whenever she gets the ENT, gets in for surgery, she can get in and do their thing. And we're going to have a different Molly on our hands when we're done with this. That family ended up referring like their whole neighborhood. I treated all their kids. And
wow.
That's not the point that I did it to get them to refer everybody. But the point is I stood out as somebody who did more for their daughter than just look at their daughter's teeth and become just a price. And I love that story because I got to watch this girl grow and develop and just change and transform. And there's nothing like that, and
you're right.
There's nothing like it. And that ties it all in. It's the additional diagnostics. It's understanding the etiology. It's working with our medical colleagues, right? Just my expansion, it wouldn't have been stable because the girl couldn't breathe. So she would have collapsed everything back. If
it's just Band-Aids. Yeah. And the relapse, it would have relapsed. Sure. Yep.
Yeah. So, it's fun. It's fun when you can do this for your patients. It's fun to do.
It's so rewarding. I had a little girl yesterday that, I told Dad we're probably going to be going in. She was a hygiene check. Mm-hmm. And so all my general dentists, primary care dentists are going to understand, we see these kiddos every 6 months and we watch them grow. And I planted seeds. I remember Mom and Dad were a little bit, again, they look at you like you're crazy. Mm-hmm. And I got them to the ENT. So I got the little one. So she's 3. I got her to the ENT. They did tonsils and adenoids. Big sister, I got them to take her too. They just did adenoids on sister. But Dad was telling me yesterday how much better her sleep is and mm-hmm. how much more calm she is mm-hmm. and focused. And this literally happened yesterday.
Changed
her life. And so I guess she is hearing Dad talk. So she's like 3.5, 4 years old.
Yeah.
And I have my hands down by her face because I always do a head neck exam. I always feel for lymph nodes and stuff like that. So I'm just feeling around while Dad's talking very casually, finishing my exam. And I'm telling him, we might need to go in and start some expansion on her because she's behind. She's got some growth deficiencies because of that airway obstruction that we need to catch her up. So as I'm feeling around on her neck, I feel her grab my hand and she pulls my arm down and like kind of wraps it around her neck. And she was mumbling something. And I swooped down. I'm like, what are you saying? And she goes, my doctor, my doctor. And she was just hugging me. And I feel,
Stacy,
it was so sweet. I'm like, oh my gosh, I wanted to just soak her up and
gobble her up.
Gobble her up. And then she kept pulling me closer and closer. And her dad goes, okay, honey, okay. I think Dr. Ochoa needs to get to her next patient. But I couldn't help but wonder, did she have some form of gratitude for what I had
without
done?
A doubt. They know that intuitively, they know you helped her. She knows that you made a difference in her, that you,
it was amazing.
Quantify it or know why, but she just knows that she didn't feel good before and she feels good now. And she was like, my doctor, my doctor. Yeah. And she kept holding me and I was
Nothing
like
it. Grateful. And I think she's hearing her dad and she's hearing conversation. And you know what I think she felt? She felt I cared for her.
Yeah.
And she heard the conversation, because people listen more when you talk about them than
completely.
To them.
That's been shown. Yeah, completely. Yeah.
So I'm talking about
I think it's Jordan Peterson who talks about that too.
Yes.
Like if you want to praise your kids, it's one nice way to do it is talk to your spouse about your child.
About them.
They're not sitting maybe right there, or even if they are, but sometimes when they're like, they can hear what you're saying. Yeah. Yep.
So I think she was feeling that we were caring and loving on her in that moment. So this was so great wonderful. Conversation. This was wonderful.
So great. So love talking with you and having these sessions. And I think it's stuff that you and I'd be talking about anyway. And that's one great part about the technology is now we can just show people like, hey, there's people who think like, people out there who think like us. Just show them like, hey, look, you're not alone. You're not alone.
You're not alone.
Those experiences you're having, the one I just described, and the ones you just described, others are having those, and they don't feel there's any voice for them. And you know what? Let's be that voice, and let's be the ones who get up there and say, no, you're doing it right. You're doing it right. Don't listen to the people who are saying you're not. You just keep doing what you're doing, and the tides are gonna turn on this.
Yes, and a rising tide raises all ships.
You got it. Yep.
So friend, let's keep talking.
Same. Yes.
Looking forward to our next conversation someday and what we have to talk about. Things are changing fast. The winds are a-changing.
They are. Yes, for sure. And keep up the great work.
Thanks, Mike.
Awesome. Take care, Stacey.
You too.
Thanks.